cheaper one, and then
cheaper.
there's one, the brand name of the micronized progesterone is called Prometrium. And
Okay.
I should just throw out there that I'm not promoting it,
Yeah.
which we're supposed to say whenever we say brand name. I'm not promoting it, but that's what it's marketed under.
called, yeah.
And so that's more expensive. But the micronized progesterone has fewer side effects, so most people, if they're recommending that medication, that sort of group of medication, progesterone, will say to go with the micronized. But Provera, the older one, is significantly cheaper, so some people will go with that. So that's male to female hormones in a nutshell, and then female to male transition, usually the only thing used is testosterone. Testosterone sort of overrides the female hormones in the body, and so it causes the ovaries to sort of go to sleep in a way, and then masculinizes the body. So you don't need a blocker the same way that you would for the male to female transition.
Testosterone's a very powerful hormone.
It is, yes.
It truly is
And
amazing.
from our perspective, very destructive to the body.
Yes.
Yeah, I mean, estrogen is also powerful, but the thing about transition is that once you have what we call the secondary sex characteristics of the hormones that were in your body to begin with, you can't undo those. So the effects of testosterone, which would be like voice deepening, growing really tall, beard growth, those things are not undoable.
Right.
And the same way if you start out with female hormones in your body, you can't undo breast development
Right.
with testosterone. So.
Yeah, it's quite amazing. My grandson is going through puberty right now. His voice is deepening. He's a sweetheart and very large.
Yes.
He's a big boy, but it's amazing the effects. And we have seen this certainly with our female to male friends and people in our group. How
They typically don't get any taller.
typically not, but the effects are very pronounced with testosterone and quick.
Yeah.
But
Yeah, and there's been more recently, there's some work being done with something called GnRH agonists, which are puberty blockers, so that people call them puberty blockers for adolescents
Right.
that are transgender. And so the idea being that if you can prevent them from developing those secondary sex characteristics, then you can transition them into their identified gender more easily. And so that's pretty amazing work, but that's very specialized.
And that's generally because, if I remember reading correctly, you don't want to put a prepubescent teenager on hormones that they wouldn't naturally be on at that stage.
I think the idea is to buy a little time to continue therapy and to work with the family and to make sure that that's really the identity of the child. And then generally, not everyone has like a set age, but I think generally around age 16-ish is when they might start hormones, sometimes a little earlier.
Because I know one of the things that we've heard from people is a fear that we're espousing putting 10 and 11-year-olds on heavy dose hormone therapy. And as a person working in that field, that's not something that's generally...
No, that doesn't tend to be done. What the GnRH agonists or the puberty blockers do is to sort of halt the pubertal development. And if you took those away, that medication away, the child would resume the normal development that they were going through.
Yeah.
So,
as you say, to buy time to continue therapy, to work with the family, and when they get to be 16, 17, 18, if it's something they want to do at that point, then they might start hormones.
Yeah. Well, exactly. It's one of the fears that we've sort of had to combat. Is there are a lot of people out there that think we're
performing surgery on trans kids.
Exactly. That we're gonna I don't know, we're stealing everybody's babies and making them go through surgery and hormones and all that. And the truth is that it really doesn't happen.
Yeah.
It's and so. Generally speaking, we certainly espouse allowing kids to sort of present however they want, but actual surgeries and hormones and things don't generally happen on children.
yeah, correct. Yeah, but a lot of people, I think, feel that if they had been able to transition earlier, had some more medical and social support, that they would not have had to go through a tough period in their life.
Oh, yeah.
So.
God. Wish I could have.
It would have made it a lot easier years ago.
But I mean, and with that, I think for most people, it's experiencing the normal puberty, not necessarily an early onset or anything. Just when you get to that, middle school, high school age, and puberty starts to set in, it just was the wrong secondary sex characteristics. But it is nice to see. We've met a number of people in their early 20s that are going down the path because they want to. And they're not dealing with the repression and the denial and the self-hate that can go along with not addressing your gender identity for 1, 2, 3, 6 decades.
Yeah. It's things have changed a lot, and that really is a wonderful thing. And the fact that you're seeing this many patients, it's clearly things are changing.
For the better.
Yeah, I mean, God, when I was a kid, I mean, this was not unheard of when I was a kid, but it was by no means
mentioned
a common thing, and it was, and medical professionals just weren't there. If you wanted to see a medical professional for anything like this, you were
went to
out of
Sweden.
the country.
Out of luck.
Yeah, and so it really is kind of nice that we're seeing a lot more of that. But we're not trying to change the gender of the whole world or anybody's children or anything. It's nice that people can be who they want to be, who they need to be.
Yep.
So.
And I think things are changing in training also. I think that definitely it's still an area that's not covered in medical school or a lot of nursing programs, but the interest is there, and I think generally people have a greater awareness of gender diversity and transgender identity. And so when I was in school, we did have some trainings that were sort of optional, lunchtime lectures, that kind of thing, and there was quite a bit of interest.
We actually had an opportunity last spring to go speak at UConn to one of the nursing classes. Not so much as any kind of medical professional, but at least from a familiarization standpoint, from a sort of bedside manner standpoint, to get to know a few transsexuals for 2 hours and talk about some of the issues that we faced and like that, and some of the good and bad stories of what's happened in various different medical settings. When you go to see a doctor or you go to an emergency room setting or an urgent care setting, you never quite know who you're going to run into. Or if you're working there, you never quite know who's going to walk through the door and maybe how to react to them.
Yep, definitely. And my experience in medicine has been that very few people really are trying to be jerks or trying to be insensitive. It's mostly that people don't have any experience or any point of reference in terms of how to respond to people, and it can sort of throw people off. So I think if people are given some tools to work with patients, they tend to be appreciative of that and take it in.
Yeah, I think that's probably the when we're talking to people, students who are going to be going into the nursing or who are in the nursing programs, going to be going into service fields. One of the questions that I know we've gotten a number of times is, well, how do I know what to call you? And it's like, ask. Do you have a name you'd prefer to use? Do you have a nickname you'd prefer to use? It's a pretty innocuous question that. And it seems simple when you sort of hear it, but yeah, if it's never crossed your mind and you find yourself in that situation, I know I get brain freeze. Oh my God, what do I do? But
yeah, and there's definitely systems issues. For example, my clinic is part of a larger system. I work within Bay State Health, which is the hospital system in Springfield, and so our electronic records doesn't offer us an option to put in a preferred name or a preferred gender.
Yeah.
So that makes it challenging for people in the office who work with 200 people a day to differentiate, who has a preferred name and who goes by their name on their chart. And so it's definitely, there's issues, that need to be worked out from systems standpoints and as ways to standardize things. And I think that's slowly happening.
And, I had an experience here since up at Bacchus, I believe it was. It was at the Pequot Medical, that's what it was. But anyways, I was there because I was feeling really sick and I was getting checked out. And the woman was checking me into the system, and I had been there a couple years earlier for something else. And she goes, well, I can't find you in the system. Would you type in your Social Security on this keypad? Oh, God. So something comes up on the screen and you see her face and her brow furrows and she's looking at it and she's looking at me. And
Yeah.
it brought up a different name, didn't it? Would you like the probate order? And it's just, part of that obviously is on our side too, to be open to that happening. And she was very nice about it. She took the probate order, made a photocopy, updated my records, and we moved on. But, it was an interesting moment when they pull up the old records and it's like, yeah, I've been here before. I don't want to admit it. Don't look. But
yeah, it's sort of impossible to hide from that, even after you're fully transitioned and all your records are changed and everything.
There's always somewhere.
Somewhere the old name will pop up, and yeah, it's kind of interesting, and it's a sort of a good icebreaker too sometimes. It's like, really, I found, I'm not going to get long-winded here, I could, but I found that people generally, most people, and it really is kind of nice, and I don't know that it's, I think to some degree it's where we live, but I think in general most people, when they find out, are pretty cool about it, and are kind of usually very friendly and sort of inquisitive, and honestly it's been kind of interesting, but you occasionally come across somebody that doesn't handle it very well, but
stops making eye contact with you.
Yeah, but most people, I think, they, and it's happened to me a million times, people will find out and they're like, oh my God, that's so cool, It's like, thank you. But yeah, there are certainly challenges. And,
you talked a little bit about the hormones. Do you want to talk a little bit about some of the risks of hormone therapy?
Sure. So again, I can sort of separate it into two groups. So on the male to female transition side, there's some sort of small risks, and then there's some bigger risks. So in terms of small risks, basically when you're on hormone therapy, you develop the sort of the profile of your gender that you're transitioning to. So for example, female to male patients will usually, their cholesterol will not be as good because men are at a higher risk of high cholesterol heart disease. So for women on estrogen, there are some risks of headaches that can happen, having your blood sugar be elevated, that can happen. Along the bigger risk category is the risk of blood clots, and you'll hear about that quite a bit because that's a very serious side effect, and that's the one a lot of people are worried about. And that used to be more common when there was a different form of oral estrogen that was used, and that was about 20, 30 years ago. There was a study that came out of the Netherlands where they looked at what they call morbidity and mortality, which is basically side effects all the way up to death for people that were on hormone therapy. And they found that this one type of oral estrogen was associated with more risk of blood clots. But when they changed the estrogen and they changed the delivery of estrogen, meaning going through the skin or going through injection, that risk kind of evened out. So we don't use that type of estrogen, oral estrogen anymore. We use different kinds. So we see fewer blood clots. But the risk still is there, and things that increase that risk would be age, smoking, because smoking increases your risk of blood